Okay, so I'm going to cover very distinct objectives for this session. So I'd like to talk about the screening tests that you all can use to evaluate for diabetes and focusing on your cardiac patients. And to apply appropriate glycemic targets for your patients, I think this is a very topical area where I get a lot of questions from yourselves. And recognizing some of the newer classes of diabetes medications and what the indications are for their use. So it should come as no surprise to you that diabetes is prevalent. When you look across the country, we come in third behind Newfoundland and Nova Scotia with a prevalence about 6.0%. It should also come as no surprise to you that that projection is going to really increase over the coming years. It's anticipated by the year 2020 that we're going to have an additional 1.2 million individuals affected with diabetes, and that's going to be around 9.9% of the population. For every diagnosed individual, there's probably another one that's undiagnosed, so you can double those rates for someone that is actually not known to have diabetes. For the purposes of this talk, I'm going to focus mostly on type 2 diabetes, and this is the definition of type 2 diabetes, where really you're talking about insulin resistance, and which may eventually develop into a relative insulin deficiency when the pancreas stops making enough insulin. Type 1 diabetes is very different. I'll just make one note to say that it's becoming increasingly difficult in the older diabetic to distinguish whether they're a type 1 or a type 2. The patients themselves may not give you the right answer to say that they're type 1 or type 2. It's not the younger, thinner person who is on insulin. You get a lot of overlap. Metformin is being used in type 1 diabetes now as well. I find probably the most useful question when you're seeing an older patient who comes to hospital is to ask, since you've been diagnosed, have you been off of insulin for longer than a day or two and didn't run into trouble? And that usually gives you an idea whether someone has been insulin dependent during their duration of diagnosis. And of course, the management is going to be very different. For your type 1s, you do not want to stop insulin at any point, particularly their background or basal insulin, because of the risk of diabetic ketoacidosis. So new CDA guidelines did come out last year, talking about newer ways to screen and diagnose diabetes. I'm going to highlight some of the differences compared to the previous set of guidelines. So in terms of screening and diagnosis, for the purposes of your population, most of your populations would fall into the high risk for diabetes category. So you wouldn't be just screening them every 3 years over the age of 40. You'd be screening them at the time that you're screening them for their lipid abnormalities, for instance, because they are high risk of vascular problems. And the way that you would screen would be with a fasting plasma glucose and or an A1C, and that has changed over the past years. A1C is now more commonly introduced as a first-line screening tool, really taking away the need to really go to a oral glucose tolerance test unless there is some ambiguity or some discordancy between those two measurements. So what are the associated risks that makes you want to screen more frequently? Well, for your patients, it's the presence of macrovascular disease, coronary, cerebrovascular, or peripheral artery disease. So if you do a fasting plasma glucose and or an A1C, and it comes back in the normal range, less than 5.6, or an A1C of less than 5.5%, they're normal. You don't need to do anything else. And at this point, you could just recommend rescreening. This could be done by a family doctor, or if you're seeing this patient chronically, you may want to rescreen in a year. If they come back in the diabetic range, that means a fasting plasma glucose of greater than 7 or hemoglobin A1C of greater than 6.5%, they now have diabetes, and you're obligated to do something about that, whether it is to recommend some initial treatment or lifestyle changes, or to refer them on to a diabetes education center. So in the absence of symptomatic hyperglycemia, even if you just have one single laboratory test in a diabetic range, you should repeat that test with another confirmatory test. And it's actually preferable to use the same test repeated in a different time. So if you did a fasting glucose, you repeat that in a couple of weeks and to see if it's still elevated. If you did the two tests at the same time, a fasting plasma glucose and an A1C, and they both come back in the diabetic range, you're done. Even if the patient is not symptomatic, you're done. They already have diabetes, you now are treating that. So in the in-between areas, this is where there could be some confusion. So this is the algorithm. So what we're looking at here really is perhaps they don't fit the criteria with A1C or fasting plasma glucose. And for all intents and purposes, again, with your vascular patients, because they generally have more than one risk factor, they usually are overweight and they have, either a family history or they have evidence of macrovascular disease, you're probably going to recommend to go on and do another test, which would be the 75-gram oral glucose tolerance test. And depending on their response to that oral glucose load, they can be subdivided into either frank diabetes, impaired fasting glucose, or impaired glucose tolerance. Now, with impaired fasting glucose and impaired glucose tolerance, they are at higher risk of developing macrovascular disease and microvascular disease. But the problem here is that we don't have a lot of great evidence that doing something in this early stage of pre-diabetes, that it actually makes a whole lot of difference. So knowing that someone is in that IGT or IFG range is important, because now you know that they're high risk of going on to develop diabetes in the future, as well as other vascular problems. But intervening at that stage is a little bit controversial. So the next thing I'm going to focus on is glycemic targets. So for a long time, we've been quoting the 7, the magic number of 7. All of our patients were drilled. You have to have a fasting glucose of less than 7. You have to have an A1C of less than 7. And this is how you know that your diabetes is well managed. Where this evidence comes from? Well, still our best type 2 trial, which is the UK-PDS, done in primary care offices, mostly in England. Back in the mid-80s, patients who were newly diagnosed with diabetes were randomized to receive conventional therapy, which is usually dietary therapy, versus intensive therapy, which is insulin plus a sulfonylurea. And in that, they were followed for a good duration of time. And in an intensive group, those that were able to get their A1Cs down to a mean about 7% did better. But where they did better really was in the microvascular complications, so things like kidney things, so microalbuminuria, retinopathy, not so much in the macrovascular disease, at least in the first report of this study. So what was interesting was the 10-year follow-up study of that particular trial, which was published a couple years ago in 2008. And what that introduced is this concept of legacy effect. So despite at the end of that initial trial, those two curves merged together. So the intensive group and the convention group, the A1Cs really just came together and it became the same mean A1C for the next 10 years. Those who had early good control actually did not only preserve their good protection for their microvascular complications, but now we also are seeing a reduction in the macrovascular complications, and it was statistically significant. So what this means is that early on in diabetes is when you should be really intervening and being aggressive. So that A1C target of 7% is going to be that way for a newly diagnosed person always. We're not going to touch that target. And probably there's evidence to even aim even lower for microvascular protection, less than 6.5%. In order to achieve A1C of 7%, what you're looking at really is a preprandial or fasting glucose of between 4 to 7. You're looking at a 2-hour postprandial glucose of between 5 to 10. If the A1C is not at target, you would want to aim even tighter for a 2-hour sugar postprandial glucose of between 5 to 8. So those are the numbers that you're going to be quoting to your patients in order to get them to that 7% target. So what's the harm in aiming for less than 7% for everybody? Well, the problem is the treatments that we have are not benign, and the most significant side effect is hypoglycemia. So the new guidelines incorporate this up to 8.5% for some people. And this is where your population comes in. Where do your patients fit? Are they in that less than 7 or somewhere in the 7.1 to 8.5% zone? So you should consider a looser or higher A1C target if someone has a limited life expectancy, if they have a high functional dependency, if there's extensive coronary artery disease at high risk of ischemic events. And this is really, the result of the ACCORD trial, which show that to be really aggressive in these high-risk patients who already have significant coronary artery disease and renal disease, and they've had diabetes for over 10 years, and they're on every agent under the sun, to be really aggressive in that population really causes harm. So you have to be careful that in someone who already has demonstrated complications, particularly macrovascular complications, that you shouldn't be lowering the A1C either too low or possibly even too fast. Multiple comorbidities, recurrent severe hypoglycemia. We don't know if it's the hypoglycemia that drove that higher risk in that ACCORD trial, but it makes sense. Certainly in the group that had the cardiac events, they had higher hypoglycemic rates because they were on more agents that could cause hypoglycemia. Obviously, in anybody who has hypoglycemia unawareness, you have to be very cautious. They can't tell you that their sugars are dropping, and you don't want to be aggressive in that case. And long-standing diabetes. And what that really is kind of loosely termed long-standing. What does that mean? Is that 5 years, 10 years? Who knows? It probably is somewhere around the 10-year mark. Sometimes people are undiagnosed for many years, so it's, again, hard to pinpoint at what point does the conditioning change or the disease change. And there are patients that we all know and patients that I follow that it's impossible. I haven't seen A1C of under 8% in 10 years, and they're already on insulin. They're already on metformin, and they're on several other agents. If I haven't been able to do it in the last 10 years, I'm probably not going to be too aggressive in trying to do it in the next 10 years. They haven't really responded very well to heavy doses of multiple agents. So for those at high risk of hypoglycemia, you're going to be aiming for an A1C of under 8.5%. Now, I do challenge you that it is it's still a very broad range. Between 7 to 8.5 is a huge difference. I think we can all sort of appreciate that sometimes it's very difficult to get it under that 7% mark, but you can probably realistically aim for either 7 to 7.5, 7.5 to 8, 8 to 8.5, and this is where the concept of individualizing the target comes in. We don't have evidence. There's no evidence that 8.5 is the magic number. So I think you have to figure out what is realistically achievable in your patient, what you have seen their A1C has been in the past, and what it takes to get them there. What that usually means for a fasting plasma glucose or preprandial glucose is somewhere between 5 to 12. And of course, avoid hypoglycemia should be a first priority. So this is just to summarize in terms of individualizing A1C targets. For the most part, most patients, majority, with type 1 and type 2 diabetes, you're still going to aim for that less than 7% mark. For anybody who's newly diagnosed, for sure, this is not the time you say, they're only at 7.1, let's keep on, trying lifestyle. No, that's the patient you should be aggressive in. That's the patient we have evidence that being aggressive actually works. And then for your patients who are frail, who've had diabetes a long time, you can maybe aim for a looser or higher target. So in terms of treatment options, again, I'm going to try to keep it straightforward. This is the algorithm that's on the CDA. They have a great website, and there's actually a CDA app if you want to download it onto your iPads or phones. I have it on mine. So really what I'm going to highlight is metformin is everywhere. So you're not going to go wrong to initiate metformin at any point in this algorithm, whether you see someone who's newly diagnosed, A1C is less than 8.5, or someone who has symptomatic hyperglycemia and they're really sick, unwell, they have polyuria, polydipsia. You can start metformin at any point. The caveat is, of course, the renal function. You do not want to start someone on metformin if their eGFR is less than 30. If they have fluctuating renal function, they're probably more at risk. And the risk, obviously, is lactic acidosis. The risk is not that high, but it does happen, and so better be cautious in anybody who has any hint of any renal instability. So I like to think of this as instead of just the A1C targets, where your role comes in. So on the far left, where the A1C is less than 8.5%, I think that's reasonable for you, if you see this person in clinic, to defer to a family doctor to say, well, you know what, they're not at glycemic, their glycemic control is not at target, they may have some element of vascular disease. Let the family doctor be aware of that fact. Let them either adjust medications, or if you feel comfortable increasing the medication, such as metformin, by all means go ahead. On the far right, I think that's more of an endocrinologist role in someone who is acutely ill, decompensating. They probably need insulin. They probably need the resources of a specialized nurse who can actually teach and adjust that insulin. So that's when you should be referring it on to somebody like me, and I'm more than happy to help out to manage that person's diabetes. In the middle is where I think most of you can fall, which is if you see someone and their A1C is over 8.5%, not at target by anybody's standards. If they're not on metformin, please start metformin, unless there is a reason not to. And you can start that. You can start low, titrate up, counsel on the potential side effect of gastrointestinal discomfort or diarrhea. But usually if it's titrated slowly, most people have minimal side effects. And then you can, if you feel comfortable, consider initial combination with another anti-hyperglycemic agent. And which anti-hyperglycemic agent? Again, individualized therapy. So it depends on what you're hoping to achieve, how much of an A1C reduction, and what sort of patient that you're dealing with. Is the risk of hypoglycemia high? Are they overweight? Do they have any other medical problems that may make a certain agent not favorable? So I'm going to mention two that are new, because I think you all know the traditional agents like the sulfonylurea or secretagogues. Those are still around. They're still very good. They're available and they're cheap. So you can always add on a sulfonylurea. The downside is weight gain and hypoglycemia. Forgot this was animated. So the newer class of agents are really the incretin therapy class, and I put the picture of the glia lizard there because it was actually isolated from the saliva of one of these lizards that it was found to have this incretin effect. Incretin is a sort of an intrinsic gut hormone that we all have, and we have now agents that promote this incretin effect. I'm just going to scan to the next slide just to show you what I mean. So with incretins, what you're referring to mostly is GLP-1, which is secreted by the intestines. These hormones, gut hormones, actually cause the pancreas to make or secrete insulin in response to food intake. They also will make you feel full because they cause the hypothalamic satiety center to feel like I've had enough and I shouldn't eat anymore. They also delay gastric emptying, which slows down the absorption of food. So works at multiple different levels, and for diabetes, it works really, really well. We have two classes of agents within this group. One is GLP-1 agonists. These are mimickers of your GLP-1, exenatide and liraglutide. And then we have DPP-4 inhibitors, which are inhibitors of the enzyme that breaks down your natural GLP-1, so allows your own GLP-1 to stick around a little bit longer and work a little bit more effectively. In your GLP-1 agonist group, they probably work better than your DPP-4. The A1C reduction is somewhere in the order of 1.5%. And the nice thing is that people lose weight on these medications because it promotes satiety. The DPP-4 inhibitors are weight neutral. They don't cause weight loss. But the advantage here is that these are oral, once-a-day medications that are easy to take. And now they come in combinations with metformin, so you can take one pill that covers both. You do have to renally dose two of them, sitagliptin and saxagliptin. And linagliptin is the only DPP-4 that is indicated for an EGFR down to about 15. So that's also nice to be able to use something in patients who have reduced renal function. You should be cautious in using these agents in anybody with a history of pancreatitis. There is an increased rate of pancreatitis with both of these agents. Anybody with familial thyroid cancer, particular type is a C-cell hyperplasia or medullary thyroid cancer. And the disappointing thing is SAVOR trial, which was with saxagliptin, also had a signal for heart failure in the group that was treated with saxagliptin. So that's being investigated. It didn't show up in the other DPP-4 studies, but you should also use that in caution with patients who have a history of heart failure. In this study, the rate of heart failure in the group with saxagliptin was about 3.4 compared to 2.8 in placebo. So not a huge increase, but the biggest predictor of heart failure was a previous history of heart failure. So again, be cautious in patients who have that history. And then the other newer class that is really just released, so canagliflozin has been in Canada now since about June. DAPA is going to be available really soon. And these are the SGLT2 inhibitors. They work in a completely novel way to reduce sugar. For years, we've told our patients that you need to control your diabetes because all of that sugar being filtered through your kidneys is not a good idea. And now we found out that, hey, we can utilize that fact and block reabsorption of that sugar. And not only do you have lower blood sugar readings, but you also lose weight because you're peeing out all of that sugar load. So it's blocking that transport reabsorption back into the bloodstream from the kidney, and they work reasonably well. We're talking about an A1C reduction of about 0.5 to 0.7%, depending on what you read. And again, it's a pill that you take once a day. Big risk is, increased risk of GU, genital urinary infections, and dehydration. So again, be cautious in people who are at risk of that. There is a slight blood pressure drop on these medications. So in some patients, that's actually a bonus, but in some patients, it could lead to dehydration. So these are sort of the quick and dirty sort of what is out there, what's upcoming in terms of diabetes medications. I think you all know that a lot has changed at the Heart Institute over the past few years. You now have a medical directive that has streamlined all the inpatients who get admitted, get an A1C done, and depending on that A1C, they get either followed in hospital or followed as outpatients. They get diabetes education right when they're here. So I challenge you to kind of think back and try to reflect and think how well we are doing here at the Heart Institute in terms of diabetes management. Do you think we're all meeting targets? Do you think we're not meeting targets? Well, I can give you the answer. So we looked at our inpatients admitted in 2012. There was about over 5,000 inpatient visits. We did about 4,000 with 3,900 A1Cs, so about 71% of these inpatients had A1Cs. And we looked at only those that had an A1C of over 6.5 because that's diagnostic for diabetes. And the mean A1Cs in these patients who are diabetic was about 8%. So you can think of it in a couple ways. Maybe it's not that bad, 8%. Maybe that's appropriate for some people. I think you'll be surprised to know that the stagger was extremely large. So we were diagnosing newly diagnosed diabetes, people who did not know they had diabetes, in about 21% of inpatients. So they came in here with an acute coronary syndrome and they were told for the first time they were diabetic. And some of them had A1Cs upwards of 12 to 14%. In the surgical population, it was also the same sort of story. In pre-existing diabetic patients, again, quite a stagger, really anywhere from people who are pretty well controlled to people who had A1Cs of over 13%. So I don't think we're doing all that well. I don't know how we're doing in the clinical setting outpatient, but at least in the patients who end up in hospital, they're coming in not knowing they have diabetes, in about a fifth of them. And for the people who do have diabetes, really they're not really at target. Definitely if we're using the 7%, they're not at target. So I think I'll end there, and if there's any questions.